to Grand Rounds. It's my pleasure to introduce today's speaker, but before doing so, I would just like to start with a land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. Today's speaker is Dr. Consolato Sergi, who is very new to Ottawa as the chief of the Division of Anatomical Pathology at CHEO. He is a professor in the Department of Pathology and Laboratory Medicine and cross-appointed to the Department of Pediatrics. He obtained his MD degree and much of his early training at the University of Genoa in Italy, including a pediatrics residency and a pediatric pathology fellowship. He then went on to further training in pathology at the University of Heidelberg, and then occupied positions in Bristol, and then undertook a PhD at the University of Innsbruck in Austria. He moved to Canada, became a fellow of the Royal College, had spent some time in Calgary, and we were very fortunate to recruit him here to Ottawa. He has an eclectic array of interests, both from a clinical and research perspective. And today he will focus on the area of celiac disease with a title, Mission Impossible, the diagnosis behind celiac disease and its mimickers. So please welcome Dr. Sergi, and we look forward to your talk.
Thank you very much, Dr. Duffy, and for the very nice introduction. And I try to share my screen. Can you see my presentation?
Yeah, you just need to put it in presentation mode.
Yeah, I do. Okay, yeah. Now should be ready. Okay, the objective, gluten-sensitive enteropathy of celiac disease. Again, thank you for the invitation. And I try to summarize a little about celiac disease, but also Mimickers, and talking about this new entity that's been, recognized in the last couple of years, which is very important as a non-celiac with sensitivity. And substantially, there's the Mission Impossible, then one of the Tom Cruise movie, and I will try my best not to go to skyscraper, but to go through my presentation in time. I don't have any conflict of interest. I tried to get involved in the Tom Cruise movie, but never mind, they didn't choose me. I don't have any affiliation with pharmaceutical, medical device or communication organization past 2 years, and I will not discuss off-label use of drugs and device during my presentation. When you look at celiac disease, people, they can see probably some kind of tip of the iceberg, and people that recognize that probably we don't see so many celiac disease patients, but it can be different because, and I will show you that at least 25% or more of these patients, that they don't have the classic symptoms that we learned in the university or in our fellowship. If you look at this nice map of Professor Brusca with advances in clinical chemistry in 2015, you will see substantially there are some specific areas that are much more involved in or having many more patients with the celiac disease than others, and you can see a part of the United States or Canada, but you can see also Germany and obviously some areas of North Europe and England and northern and northern Italy as well, but also interesting Saudi Arabia, Iran, and also Mongolia or Australia that has been identified. As I said, the symptomatic prevalence, we look at Alzheimer's failure to thrive, but substantially in 25% are very different diversity present of symptoms. The symptoms can be very different. And I will try to summarize how we will try to see, not to focus only on the ESPGHAN, European Pediatric Society of Pediatric Gastroenterology and Nutrition criteria, but also to other societies to look at what we can do better for our patients. And well, look at for the definition, and this definition has came out over the years, and it's not only an autoimmune disease. There are genomic or genetic component, but also epigenomic component. And no wheat, rye, and barley should be given to celiac patients. So we know that there is an attack against the surface epithelium, and the architecture of the villi is destroyed. And this patient experience malabsorption with the range of symptoms and diseases, including osteoporosis, iron deficiency, anemia, infertility, cancer, autoimmune disorders of the type. And GFT is crucial because the GFT then they will help to restore the architecture of the gut, unless you have a refractory celiac disease. If you look at, there are only 2 slides on pathogenesis that I prepare, and they are compromised barrier function of the small bowel epithelium with gliadin peptides entering the lamina propria, and the ubiquitous tissue transglutaminase is activated and process to process the gliadin peptides in deamidated gliadin peptides, what is also known now as the DGP. The DQ2 and DQ8, which are 2 HLA components that need to be present, are expressed on antigen presenting cells, mainly macrophages, dendritic cells, and B lymphocytes. The DGP are inducing or induce substantially an immunostimulatory response on APC, and CD4 T cells are activating, and mainly CT with the Th1 cytokines, and the CD8 the T cells produce or induce the progressive villous atrophy. Now, the villous atrophy is the histological marker of celiac disease, but not all patients develop or have till the end subtotal or total villous atrophy. Sometimes you have mild morphological patterns, and the Th2 cytokines are also produce autoantibodies to gluten and tissue transglutaminase. Now I wanted to show you some pictures. This is villi, and you can see the progressive villous atrophy. Now, if you look at that, here's a schematic drawing of so small bowel. You never have so easy to see in histology. Most of the times you get this kind of pattern, morphological pattern, and this is practically linked to what you have in substantially villi that are slender, long, the presence no evidence of abnormal architecture. Now, there is when we go ahead in the setting of a celiac disease, these villi will disappear progressively, and you can see this is practically another patient showing substantially partial villus atrophy with villus to crypt ratio, what we call villus to crypt ratio reduced, or even quite reduced, or completely nil. And you can see a total villus atrophy. Now, there are two classifications. They are substantially used in pathology and in pediatric gastroenterology. One is the Marsh-Oberhuber classification with 5 mucosal injuries, type 0, or the pre-infiltrative, normal small intestinal mucosa with less than 30 intraepithelial lymphocytes per 100 enterocytes. Now the number 30 changed over the years from 40 to 30, and as some people suggested, should be now 25, but we keep the Marsh-Oberhuber on 30 intraepithelial lymphocytes. The type 1, when you have the infiltrative type, you have a normal villus and crypt architecture, but an increase in intraepithelial lymphocytes. And the type 2, where actually you have the crypt hyperplasia with presence of increase in intraepithelial lymphocytes, what I show in the previous slides, and presence of here and crypt hyperplasia. And then in type 3, when there is a flat mucosa on endoscopy, you can see 3 different subgroups: mild villus atrophy, marked villus atrophy, or total villus atrophy, or subtotal villus atrophy. Most important, there is a type 4, which hypoplastic flat mucosa with only a few crypts and near normal intraepithelial lymphocytes. Now, type 4 is mostly never seen in the in the routine. Professor Corazza and Professor Villanacci, they worked on this classification, and they identified that there is the Marsh-Oberhuber, which is the current classification that we used in the routine, has some glitches, because obviously the type 4 you've never seen, and is sometimes more or less difficult to apply. And they proposed the grade A, B1, and B2. Corazza is a gastroenterologist, and Villanacci is a pathologist. The grade A, which is non-atrophic, not normal architecture, B1, atrophic with decreased villus to crypt ratio, but increased intraepithelial lymphocytes, and atrophic and flat with villi not detectable, but increased intraepithelial lymphocytes. Now, if we look at the Marsh-Oberhuber classification with the Corazza-Villanacci classification, you can see that Marsh type 1 and type 2 practically are in line with the grade A, the 3A and 3B with B1, and 3C with total villus atrophy with B2. Never mind that the Marsh-Oberhuber classification is still the standard to classify duodenal biopsy. But I just wanted to make sure that you look at which classification we use or is written in the report. Now, mimickers are very important because not only celiac disease, you can see a lot of different agents, and there are few of them we can catch on using special stains on histology, like Mycobacterium avium intracellulare, or cytomegalovirus using immunohistochemistry, or specific Giardia lamblia. And I will show you a few cases that show that as a mimickers of celiac disease. One characteristic that we need to keep in mind is the peptic bulbitis, and some of these are linked to some degree of atrophy. And in this patient, you see obviously some intraepithelial inflammation, but also quite a lot of clusters of neutrophils, which allow you to suggest the diagnosis of peptic bulbitis. Another important that I suggest is to the gastroenterologist to send us not only the duodenal biopsies, but also the gastric biopsies to look at these microorganisms, this Helicobacter pylori. This is 630 magnification, and you can see this practically what you see substantially on sometimes a saddle, and it's difficult to see massive presentation of Helicobacter pylori. And in some cases, some intraepithelial lymphocytosis of duodenum is associated not only with Helicobacter pylori, but also with Helicobacter heilmanni. Another important mimicker that can trigger presence of villus intraepithelial lymphocytosis is the presence of lymphocytic gastritis. And I'm not going to talk about autoimmune enteropathy because it would be not part of the presentation and not one of the objectives of the lecture, but just wanted to point out that it's crucial to look at different criteria and also to see if apoptotic bodies are present, which are the characteristic features of autoimmune enteropathy. Sometimes it's important also to look at cases that can be very problematic for the medical legal perspective. This was a case where actually it was at first glance diagnosed as celiac, but is something different. Is not only presence of this hyperbasophilia, has a lot of cells here, with it's a characteristic feature of an adenoma. And this is a patient with familiary adenomatous polyposis, and this is practically a patient with FAP tubular adenoma. And we are going to look at more in details this aspect. You can see that these cells, and of course you can see some of them, they are lymphocytes, but most of them, they show you the presence of hyperbasophilic cells with loss of goblet cells. And this is a very important topic to look at also mimickers to rule out neoplastic diseases. This is another mimicker that you can have intraepithelial lymphocytosis, And you can see this is now we are on the duodenum with presence of lymphocytes populating the enterocytes on the surface, but you see also this microorganism is oval shaped, some or discoidal shaped, and these are characteristic giardia lamblia patient. Another intraepithelial lymphocytosis that you can have is in cases in patients with eosinophilic duodenitis. It's also not part of the discussion today about the correlation between EE and celiac disease as identified by numerous groups, but eosinophilic esophagitis has been associated to the eosinophilic to the celiac disease. Now, we look at the next categories, and that's I try to schematize this villi. Of course, when I look at this villi, and we did also different studies with Dutch colleagues, and you can see that in the case of celiac disease, the intraepithelial lymphocytes populate the upper tip of the villus, instead scattered intraepithelial lymphocytes on the side of the villus can be seen in other pathologies, and specifically in inflammatory bowel disease, ulcerative colitis, and Crohn's disease, and substantially down, and you can have in graft versus host disease, as well as other autoimmune disorders. Now the concept is to count exclusively when you are dealing with celiac disease, count the 5 tips of villi, so 20 enterocytes, and 20 by 5 100, and you can double check, you can identify the substantially the 100 enterocytes, and then you count the number of enterocytes that you have. Criteria and standard for diagnosis. We know that villus planting, intraepithelial lymphocytosis, cryptoperplasia, and plasma cell-rich inflammation are characteristics. But I just want to make sure that it's clear. The celiac disease is an patchy disease, and it's very important to have at least 6 or better 8 biopsies, at least 2 per site, bulb, proximal, mid, and distal duodenum. We need to, at least to evaluate correctly, we need to have 3 consecutive and intact villi, and probably 5 when is better. In this way, I stressed for many years that our pediatric gastroenterologist to give us 6 to 8 biopsies and 2 from the bulb. And the virus to crypt ratio is also clear and very important. That it needs to be 3:1 or 4:1. When it's practically lower, is a presence of villus atrophy. But there is also some peptic injury related changes in bulb, and these need to be discussed with pediatric gastroenterologists as well. In summary, people that suggest even 20 per 100 epithelial cells may suggest the presence of celiac disease, specifically if these lymphocytes go toward the upper tip of the villi. And as I said, the IBD In case of IBD patient, you have on the villus site, and GVHD allograft rejection you can see in on the villus tip on the crypt. Synoptic protocol has been supported by the Association of Clinical Pathology, and substantially is very useful, not only for studies on randomized clinical trials, but also on clinical aspect. Then important is to identify the number of treated lymphocytes on top, side, and down, and the enterocyte damage, the brush border thickness, the erosion, the presence of microorganisms as identified by special stains, and immunohistochemistry, and avoiding to miss dysplasia or malignancy. It's a never-ending story because there is a substantially ESPGAN, the European Society of Pediatric Gastroenterology and Hepatology and Nutrition, as well as the American Gastroenterology Society and the World Society of Gastroenterology. They have different screening methods, and as you know, that screening is a little different between Europe and North America. Substantially, the screening test started with an anti-tissue transglutaminase IgA and IgA for ESPGAN or NASPGAN, but the HLA-DQ or DQ2 and DQ8 is important to perform if you have an antibodies anti-endomysium and or increased TTG. A normal pattern of duodenum, but they substantially there is no common agreement on all diagnoses of between the different societies. But the point is that in some of these societies are more linked to pediatrics. Some they mixed pediatrics and adult patient, and others they don't target a specific cohort of patients. The National Institute for Clinical Excellence in the UK, they substantially, it's important to suggest that GSE as celiac disease or gluten-sensitive enteropathy when some signs are present, like we discussed failure to thrive in children, diarrhea, persistent unexplained gastrointestinal symptoms, prolonged fatigue, and recurrent abdominal pain, sudden unexpected weight loss, and unexplained iron deficiency. Now the problem is not only to diagnose a celiac disease, the problem is also to avoid that people label themselves celiac. And this is has been long years one of the discussion about fake news or presence of over calling celiac or gluten-free diet for patients and not having celiac disease. I was fortunate to cooperate with the first, the BCR Kiersky and Carroccio were practically two, and Carroccio published in American Journal of Gastroenterology the first, both at the same time, the first rational randomized clinical trial on non-celiac wheat sensitivity. Now, these patients are different. First of all, these patients are different. They are not celiac disease. But they have sensitivity or hypersensitivity to wheat. And this is very important to say. Though many people they just label themselves celiac or wheat sensitive and started a gluten-free diet, which can make some difficulties, not only for the pediatric gastroenterologist, but also for the pathologist. The current criteria for non-celiac wheat sensitivity relies on CATASI two-step algorithm. There's a rule out celiac disease and wheat allergy, skin prick testing, serum IgE, oral food challenges, and a gluten-free diet for 6 weeks. There is a specific scoring panel for symptoms before and after 6 weeks of gluten-free diet. And non-celiac wheat sensitivity can be diagnosed only if the patient has no symptoms after gluten-free diet. But this is just the first step. If not, of course, you need to go ahead with an additional investigation. But then the second step involves a double-blind crossover design challenge with Salerno criteria, 1 week challenge with 8 grams of gluten in capsules with the amylase trans trypsin inhibitors, and also fructose and FODMAP free vehicle, and in the gluten-free placebo. That substantially you have the challenge, and after 1 week washout, and then you can make a safe diagnosis of non-celiac wheat sensitivity. This is why the Salerno criteria are key. And but obviously, if you look at the wheat, rye, and barley, the part of the graminae or graminales, and you can see all this taxonomy of the plants. There is also a risk of cross-contamination, specific in some plants. They practically deal with some of the wheat, rye, or barley. But one important aspect that I would like to also point out is that if patients start a gluten-free diet, can be a problem not only for the pediatric gastroenterologist or for the pathologist to make the diagnosis, but also for a few problems that can be present. Because gluten-free diet, you can have hyperglycemia or hyperlipidemia, but also as a coronary artery disease or fiber deficiency, and obviously all gluten-free diet food, most of them, they're very expensive. And substantially, there is what we call social restriction, and this is one aspect that we published with recently with Villanacci and Carroccio. And important as the social media have been practically pushing a lot of people in this gluten-free diet, not having any evidence of non-celiac wheat sensitivity. Professor Villanacci and I and Professor Carroccio, we look at specifically some of these patients with non-celiac wheat sensitivity. And we found that there are some aspects very interesting. There is a normal villi, no evidence of villous atrophy, but there are some clusters of T lymphocytes in surface epithelium, and there is a linear array of T lymphocytes at the base of mucosa and eosinophils around. And this is the concept is there is a role from mucosal histology in the non-celiac wheat sensitivity. Yes, and this is the University of Brescia experience. Nearly normal T lymphocytes, practically less than 25 per enterocytes, per 100 enterocytes, sorry, and an array of T lymphocytes in small clusters, linear distribution of T lymphocyte and lamina propria, and an increased number of eosinophils in the lamina propria, more than 5 per high power field. Now, these are substantially criteria that have been practically brought in the last probably couple of years, and we are focusing on substantially try to consolidate this group on non-celiac with sensitivity and separate it from the celiac disease. I would like to say it's not probably impossible. It's slightly possible to make the diagnosis of celiac disease and non-celiac with sensitivity today. And I would like to thank you very much for your attention.
Thank you very much, Dr. Sergi. That was really an excellent overview. You've highlighted a lot of issues, some of which are clearly controversial, and really have emphasized the importance of the differential diagnosis and really of the relationship between the gastroenterologist and pathologist. I have a question with regards to the classification or grading of disease as to what extent that is time-based, as in the time at which a diagnosis is made, and whether individuals are going through different phases versus disease severity from a genotypic perspective. Could you comment on that?
Yes, it is substantially linked to the severity. I have to say that's because I discussed about one autoimmune, genomic and epigenomic disease. We know that there is some epigenetic components in celiac disease. They may play a major role in how the severity is present. And in fact, the tissue transglutaminase levels is not associated. There is no correlation with histology. But also I wanted to point out at this point, I stress, sorry, about patchy disease. It's really patchy disease. In this you can get 5 of the 6 from the duodenum normal, and then you have 1 which is abnormal. And that's crucial that we can make the diagnosis, because if we don't make the diagnosis, this patient can have a failure to thrive, and then obviously develop also the major problems later in life.
We're open for questions or comments. If anybody wishes to do so, please put up your blue hand so I can see it and direct the question. Don't see any so far or anything in the chat. We have a shy audience today.
I think pathology is sometimes the dry.
Hello, may I ask a question?
Dr. Batra.
Yeah, I was wondering, you showed the world map in there, and that was showing in African countries very minimal involvement. Now, does it have to do with genetic factor, or it has to do something with the diet of African people?
That's a very good question, and I have to say, I can say I don't know, because it's essentially both components can play a major role. We know that if we look at specific areas like Sardinia, and you can see high celiac disease, or in Saudi Arabia, they are both quite different, but there is also a component, a diet component, where actually the gluten is started earlier than normal. I don't. I cannot say there is only genetic component, but there is also an epigenetic component. Probably that's the environmental factors play a major role in celiac disease, how to develop. Probably also on the patchiness of the disease.
So we have a couple of questions in the chat. I'll go to Dr. Venkateswaran, one of our neurologists, who has a question about gluten ataxia. Maybe you'd like to elaborate on your question, Sunita?
Sure, no problem. Thank you for your talk. I was wondering if you can tell us a little bit about the pathophysiology and the incidence of gluten-induced ataxia, because I know it's very rare, but that it does exist, but I don't really understand the pathophysiology behind it.
Yeah, I never seen a patient with the, I have to say, my gluten ataxia, but I heard about this condition. It's rare. We don't know exactly all the aspect, but what we know as we suppose that there is some neurologic, what we consider probably, and discussing with other pediatric gastroenterologists, is that you know that there is a couple of papers that came out in the last probably 6 months about gut neurosystem, and there is more than and these axes are linked now to an important factor, which is the microbiome. Potentially, you know, it's I won't say, I cannot say for certain, but obviously people, they suggested that some of neurological problems that you have are not only linked to the vagal or to this neurological system of the gastrointestinal tract, but can also be linked to the microbiome. Said that the consideration of ataxia can also be not only linked to exclusively to the presence of this gut neurological system axis, but also to deficiency of specific elements in the diet, because these patients have a substantial malabsorption, and a malabsorption can be, as you know, associated with cerebellar and extrapyramidal problems. I think this is I have been in discussions, but this is the up to date what we consider at this stage.
There is another question from one of our gastroenterologists, Dr. Mohit Kahar. Mohit, maybe you'd like to address your question.
Yeah, definitely. It was a great talk, Dr. Sergi, and you know, there has been some thoughts that celiac sometimes starts in the proximal duodenum and it moves distally, and that was one of the hypotheses and the thoughts behind taking more duodenal bulb biopsies when it all started. So, what's your talk on that? Thoughts on that? I understand it's patchy, but do you think it moves from proximal duodenum to distal?
Yeah, as you know, there is a wonderful article from the Nova Scotia group that they published on bulb restricted or the bulb predominant celiac disease. I consider that it is still patchy, and in probably some groups they start really from more on the bulb. What is challenging is, and remains challenging, is important to rule out Helicobacter and rule out peptic associated injury. That this is a very important aspect. And in my consideration is remain the diagnosis remains patchy, and I don't or to say not in all patients can start essentially from the bulb. You can also have in the location, but probably one cohort of patients can have this gradual progression from bulb to the distal duodenum. But all the times it's less important is 6 to 8 biopsies to the pathologist.
Surely, thanks.
I don't see any other questions either in the chat or any blue hands. So we'll draw it to a close. I'd just like to thank you very much, Consolato, for an excellent presentation, for taking us deep into the gastrointestinal tract, and look forward to you interacting with the members of our department, and a very warm welcome to you to CHIO, and we look forward to interacting in the future.
Thank you very much for the invitation, and thank you, Dr.